Good morning, everybody. I'm Yamada, Transplant Nephrology Fellow. And yeah, it's a great honor to be presenting at the Grand Round today. So today, I would like to study about cross-match with all of you guys. And I don't have any COI to disclose. So let me get started with a case presentation. 67-year-old female who had an end-stage kidney disease due to diabetes and hypertension and hyperlipidemia. She presented here for the kidney transplant. Then her calculated pioneer reactive antibody, CPRA, was 96%, and she had weak antibodies, both class 1 and class 2, against the potential donor. And then her flow cytometer cross-match was positive, and MCS was 17 in T cells and then 16 in B cells. So she underwent the plasmapheresis prior to the operation. And the procedure was uncomplicated and allograft functioned promptly. But yeah, there are many medical jargons surrounding cross-matching, which might dampen our interest in this topic. So today I'd like to just, provide some background information to help make cross-matching more relatable and understandable for everybody. And my hope is that by the end of this talk, you'll feel more comfortable and at ease with the concept of the cross-match. So this is the outline of today's talk. First, I will begin with an overview of cross-match, followed by discussion on CPRA and virtual cross-match. Then finally, we'll briefly touch on the emerging topic of Eplet matching. So before delving into cross-match, let's take a step back and explore the concept of the HLA. Since understanding HLA is pretty crucial as it forms the foundation of the cross-matching process. Then after that, we'll discuss the two major cross-match methods, complement-dependent cytotoxicity cross-match, CDC, as well as the flow cytometer cross-matching. The genetic loci involved in the differentiation between self and non-self are known as HLA, human leukocyte antigen. And HLA maps to the short arm of chromosome 6, and it has two classes. And then class 1 contains HLA A, B, C, and that encode a heavy chain of the class 1 molecules. Then class 1 molecules consist of heavy chains with 3 domains, alpha 1, alpha 2, alpha 3, as well as the non-covalently bound extracellular beta 2 microglobulin. Then class 2, on the other hand, heterodimer of alpha chains and beta chains. Then, class 2 genes including the DP, DQ, DR. Then HLA class 1 molecules are expressed on the surface of almost all nucleated cells. On the other hand, class 2 HLA molecules are expressed only on B lymphocytes, antigen-presenting cells such as monocytes, macrophages, and dendritic cells, and activated T lymphocytes. Then class 1 HLA recognized endogenous antigens. These antigens are derived from such as cancer cells or virus-infected cells. And in contrast, class 2 recognizes exogenously derived antigens, for example, the extracellular bacteria. Then class 1 molecule peptide complex is recognized by CD8 positive T lymphocytes. Then in contrast, class 2 molecule peptide complex is recognized by CD4 T lymphocytes. And I cannot talk about cross-match without mentioning Dr. Paul Terasaki, known as the pioneer of cross-match. After working under Sir Peter Medawar, known as a father of transplant, and he worked at the University College London, and he studied mainly antibodies in transplantation. Then Dr. Terasaki suspected that preformed antibodies against donor cells are responsible for immediate failure of kidney transplant. And in 1964, he introduced the microcytotoxicity test for detecting anti-HLA antibodies and typing and for cross-matching. And Dr. Terasaki and Dr. Patel reported that positive cross-match was associated with high risk of immediate allograft failure, which is published from New England Journal of Medicine. So since then, cross-match was quickly adopted as the international standard. And the test Dr. Terasaki pioneered, it's called complement-dependent cytotoxicity cross-matching, or CDC. So first, lymphocytes from the donor are isolated and separated into T cells and B cells. And then serum from the recipient is mixed with the lymphocytes. Then the complement is added, usually derived from rabbit serum. Then if donor-specific antibodies presents, the complement cascade is activated by the classical pathway, which results in lysis of the lymphocytes. But CDC crossmatch has limited sensitivity and specificity. Now we use flow cytometer crossmatch as a standard. So flow cytometer crossmatch is performed using the same initial base ingredient as CDC crossmatching. So donor lymphocytes separated into T cells and B cells, and then a recipient serum is added to the donor cell lymphocytes. Then next we add a fluorescent labeled antibodies against human IgG. Then intensity of the fluorescence peak subtracted by negative control is semi-quantified as median channel shift, MCS. So cross matches are performed with both T cells and B cells. And then as a reminder, T cells carry class 1 HLA, while B cells possess both class 1 and class 2 HLA. So in cases where a patient has class 1 antibodies, both T cells and B cells cross-match should yield positive results. On the other hand, if the patient has class 2 antibodies, only the B cell cross-match will be positive. To recap, in the realm of HLA, class 1 encompasses HLA A, B, C, and these molecules are widely expressed in nearly all nucleated cells and primarily recognize endogenous antigens. And in contrast, class 2 genes include DR, DQ, and DP. They are expressed only on the APCs and recognize antigens derived from the external sources. Then cross-match serves as a pivotal tool for assessing preformed antibodies against allograft. Initially, CDC cross-matching were the primary methods. Now, flow cytometer has emerged as the current standard due to its enhanced sensitivity. Any questions so far? Okay. Let me move on to the next topic. So next, I'll quickly talk about the CPRA. And to be honest, I had no idea what CPRA means when I did my first pre-transplant evaluation during my general nephrology fellowship in Pittsburgh. So first, quickly explore the definition of CPRA, followed by the technique used to estimate CPRA. Then we'll take a look at its impact on allocation systems. Calculated panel reactive antibody, CPRA, is a measure used to estimate the likelihood of encountering the incompatible donor. Then data set is obtained from the National National Marrow Donor Program, NMDP, donor registry as a representation sample of the potential local organ donor pool. And for example, CPRA of 10% means that the patient's HLA antibodies are incompatible with 10% of potential donors. So we need to determine the specific antigens to which the potential recipient has developed antibodies. So the HLA antibodies are assessed with a single antigen-based assay. Assay kit has approximately 100 beads, and each bead is impregnated with two fluorophores and coated with HLA antigens. Then, when a potential recipient serum contains antibodies against HLA antigen, they bind to the appropriate bead. Then, after that, secondary antibodies for human IgG were attached. When the combination of the fluorescence signal is possible, it will be detected by the Luminex system. Then the intensity of the fluorescence signals can be semi-quantified by the mean fluorescence intensity, MFI, although MFI measures cannot directly be converted into antibody titers. So the highly sensitized patients face challenges because their extensive immune response often leads to positive cross-match with nearly all organ donors. So the new kidney allocation system implemented in 2014 assigns priority points based on the sliding scale. So for example, the CPRA 99 patients received a 50.09 allocation priority points. So this is the interim summary. So CPRA, calculated panel reactive antibody, is the measure used to estimate the likelihood of encountering a cross-match incompatible donor. And HLA antibodies are assessed with single antigen-based assay. They detect HLA antibodies by the Luminex system. Then the new kidney allocation system in 2014 assigns priority points based on the CPRA. Any questions so far? So the third topic is about virtual crossmatch. While the term virtual may evoke some images of the cutting-edge technology, in the context of crossmatch, it simply refers to predicting immunologic compatibility based on the single assay results. Virtual crossmatch offers some advantages, including reducing the unnecessary physical cross-matching and decreasing cold ischemia time, thereby enabling organ sharing over extended distances. Then enhancing the likelihood of finding cross-match compatible donor for highly sensitized patients. Then several studies investigated the safety of virtual crossmatch, since there is some possibility of discrepancy between the physical crossmatch and the virtual crossmatch. And the left side, this one, is a retrospective study from UCSF. Then they performed 254 kidney transplant. They followed 254 kidneys implanted between December 2014 to October 2017, and then about 84% 215 were transplanted without a pre-transplant physical cross-match. Then among 215 patients who were transplanted based on a virtual cross-match, there was no hyperacute rejection, and then very infrequent acute rejection, and then T-cell mediated rejection was 1.9%, and the antibody-mediated rejection was 6.5%, and the mixed was 1.4% in the first year. And then another retrospective study from, I think it's from Emory University. They compared the result of the flow cytometer crossmatch and the virtual crossmatch in 100 living donor recipients. And then there were 25 discordant cases, and then 5 were virtual crossmatch positive, then flow cytometer was negative. And 20 were the opposite. Flow cytometer was positive, while virtual crossmatch was negative. Then for those 20 cases of the flow cytometer was positive and virtual crossmatch negative, 8 patients were transplanted, and none of those recipients experienced early antibody-mediated rejection. Of note, some of these false positive cases, patients had autoantibodies. Then the last topic is emerging one, the Eplet matching. So traditionally, HLA mismatch was the primary focus on assessing compatibility in transplantation. However, recent insights suggest, sorry, I got a page. Insights suggest that the traditional HLA mismatch alone does not always directly correlate with the autoimmune injury. To better understanding compatibility, we need to examine HLA mismatch at the molecular level. And then even though the HLA system is pretty polymorphic, there are some significant homology within it. So eplets are small surface exposed patches of amino acid on HLA molecules, then acting as a immunologic hotspots, which is pretty crucial for compatibility determination. So conventional HLA typing alone cannot determine the immunogenicity of non-matched HLA antigens, as it treats all non-matched donors equally mismatched. However, certain HLA alleles exhibit molecular similarities, enabling us to assess the immunogenicity of non-matched HLA antigens more accurately. For example, if the donor has DQ5 and the recipient's potential and recipient have DQ8 and DQ9, we call it just a HLA mismatch 1. But HLA8, DQ8 and DQ9 share some homology. So Eplet mismatch is totally different between DQ5 and DQ9. Then Eplet mismatches, particularly in class 2, pose a significant risk of the developing donor-specific antibodies or antibody-mediated rejection and ultimately graft loss. This association is more significant compared to mismatch itself. HLA anti-mismatch, I meant, sorry. So conventional HLA typing provides relatively limited insights into the degree of match or mismatch between donors and recipients. In contrast, Eplet matching explores much deeper into assessing the similarity between HLA molecules. So asking not just do they match, but how similar are they? So this approach holds some particular promise for highly sensitized patients, since assessing the immunogenicity of potential donor organs can broaden so that, broadens their chances of acceptance. So the question remains, will Eplet matching eventually replace conventional HLA typing? Well, it offers a significant advancement. It still cannot completely predict Eplet matching and the resulting pathogenic response with absolute certainty at this time. But I'm looking forward to the future. At some point, we use Eplet matching as a mainstream of the matching before before transplantation. So to summarize today's talk, HLA has two classes. Class 1, which are expressed in all nucleated cells, while class 2 are expressed only on antigen-presenting cells. And then we discussed three types of crossmatch: CDC, flow cytometer, and virtual crossmatch. And Eplet matching offers deeper insights into immunogenicity. I really appreciate Dr. Idoya and Elaine from Bloodworks, as well as all the attendings at UW Transplant Nephrology. Thank you very much.
Thanks so much, Taka, for that nice review and update. Any questions for Taka?
Hey, Taka, that was a nice talk. Do you see a future where we expand to non-HLA antibodies like AT-R1 antibody and so forth?
It's a good question. Thank you for asking. To be honest, still we have too many unknown stuff regarding the non-HLA antibodies. Then it's still really difficult to detect the non-HLA antibodies. So I'm still looking forward to the future, but so far we don't have a good way to figure it out.
I'm curious, Taka, just since xenotransplant has been so in the in the discussion, and feel free to defer. It's a little outside of your talk, but what does antibody assessment look like in a future of xenotransplantation?
It's a good question. Sorry, it never occurred to me. So it's going to be totally a new world. So I have no idea, to be honest. Sorry.
All right, some plaudits in the chat. If no other questions for Taka, we'll let you answer your page and and move on to our next speaker. Thanks so much.